Thank you. All right. Hi, everyone. Dr. Chan is a hard act to follow. I don't talk about prostitutes or testicles in the next few minutes here. But I am Lindsey Davis. I'm a medical oncologist at the university, and we're going to talk about early onset colorectal cancer today. I do want to give some credit to my co-lead of GI medical oncology at the university, Dr. Chris Liu, who created most of these slides. And let me just, okay. So first and foremost, what do we mean by early onset colorectal cancer? So what we mean is the diagnosis of colorectal cancer less than age 50. And so that's what we're really going to spend the next 20 minutes or so talking about together. We'll talk about the incidence and trends. We'll talk about how these patients may present, and then also research into why this is happening. And so first and foremost, let's talk about why this is an issue, why I'm here talking to you guys about this today. What we know is that the incidence of colorectal cancer is overall decreasing in the older populations. And so we can see here in the top two or left two graphs that in age groups 50 to 64 and 65 plus, the good news that we see colorectal cancer diagnosis decreasing from the late 90s to 2019 when this was last evaluated. We can also see mortality is decreasing in these groups as well, a lot because of that decreased incidence, but also because of improvement in treatments and therapies for those who have later stage disease. However, that is not the case for the 20 to 49-year age group. And you can see here in both males and females, that same time period from the late 90s on, there's been a rise in incidence of colorectal cancer. And so if we think about this, about number of new diagnoses per day in this population, it's equivalent to about 49 new diagnoses of patients between 20 and 49 with colorectal cancer in our country. Also, if we look at mortality, we can see that though there was a dip in the 90s when we had all those new therapies developed, just in the same younger age group as the older age groups, we're now seeing that on the rise. So in spite of these same therapies we have available for these younger patient populations, we're seeing the mortality rate increasing. And in fact, if this continues on this trend, colorectal cancer will be the #1 cause of cancer death in people in this age group by 2030. And that's not far away, you guys. This looks at it in a slightly different way. So this is looking at birth cohort. And basically what this means is that if you were born in 1955, when you were age 40, your risk of developing colorectal cancer was much less than if you were born in 1980, like me, and you're age 40. And so this kind of hints to us that there's probably something about an exposure throughout our lifetime that is increasing the risk of colorectal cancer in these young populations. These graphs look at it a little bit more closely in terms of exactly where in the bowel may this increased risk of cancer be driven by. And so it's divided on the left by colon cancer and the right by rectal cancer. And what we find is that rectal cancer seems to be even more prevalent in these young populations. So if we look at the blue line, which is the very youngest population, ages 20 to 34, we can see that by 2030, it's estimated that there will be a 90% increase from 2010 in incidence of colon cancers, but 124% increase in rectal cancers. And that's similar for the next age group of 35 to 49. You can see 27 to 46%, whereas those older age groups, the incidence rate is staying pretty similar. So trying to get hints of not only where in the colon may this risk be increased, but what are the other potential risk factors that may be playing a role. So if we look at geographic areas in the United States, we can see first and foremost over time that the incidence is increasing. And so these figures are showing us in the white or lighter blues are lower incidence of early onset colorectal cancer. And as the blue gets darker, navy blue in color, that's the highest incidence rates. And the top left is starting with 2001, and then the bottom right is the most recent data from 2017. And you can see that by all means, as we go through over time, the colors are going from a light blue to darker blue. But also if you notice, it seems that this is happening most prevalently and kind of earliest in the southeast of our country, in the southeast United States. If we take a bigger view and look at what's happening worldwide, this is not just something specific to our country. We are definitely one of many that is driving this early onset colorectal cancer trend globally. And it's mostly developed countries, as you'll notice. So we're in company with Australia, New Zealand, Korea, many countries in Europe, areas of South America, and Africa as well. So I think the key thing I want you to remember today about this is that the incidence of colorectal cancer, and particularly rectal cancer and those descending colon cancers in young patients, is increasing in our country, but also worldwide. And that varying trends seen across our country seem to be most significant in certain parts of our country in the Southeast region. So we think about this as we're thinking about what are the causes and why is this something that we're seeing. Let's talk now about how these patients may present. This is a survey from 2020 where they asked 884 patients and survivors about symptoms they experienced related to their colorectal cancer diagnosis. And the mean age in this group was 42. And you can see the things we might expect, right? So highest reported symptom, blood in the stool, also fatigue and abdominal pain. And I think, blood in the stool is pretty striking and something that you'd think would make someone take note. But some of these other things like fatigue, flatulence, bloated stomach, constipation, those may be less likely to bring somebody to the attention of a doctor or a doctor to take seriously if they go in with these complaints. And I think this kind of better exemplifies this. So this is a cross-sectional survey of over 1,000 patients who are survivors of colon cancer at a young age onset. And 63% stated that they were actually not aware that colorectal cancer could even occur in patients less than 50 years old. And so that then doesn't make you surprised to hear that 41% of these patients waited more than 6 months before they sought medical attention for these symptoms. I think also important, though, is this next table, which tells us that 67% of this population saw 2 or more physicians before they were diagnosed. And so it's not just a problem that we need to educate patients in this age group that colorectal cancer is on the rise and something you may experience and see, but also the physicians who are seeing them and the care team that's involved in their care. We also need to be aware and think of this as a very possible cause of these symptoms the patients are experiencing in this less than 50 age group. And so I think in these studies, there's kind of a trend over and over again of what are the common things we're seeing in this age group. It's not too different than what we would expect in people of older age in terms of symptom presentation, but maybe a bit less specific. So abdominal pain, rectal bleeding, diarrhea, and iron deficiency anemia. But you can also see in this table that it shows that it's easier for us to make a diagnosis of colorectal cancer in this young age group if you have more than one symptom. So when a person presented with only one of these symptoms to their medical team, the median time to diagnosis was 9.7 months, almost a year. When you had 2 symptoms and then even more 3 or more symptoms, that time frame significantly decreased. But I think the trouble with that, of course, is that if you're hanging out with symptoms related to a colon cancer for almost a year, then the odds are your cancer is growing and you have a higher risk that this cancer is going to be more advanced at the time it is diagnosed. And so that's what this data showed. You can see that this was specifically looking at bleeding, which again we think of as kind of being the most obvious or concerning symptom that would bring someone to medical care. And that this is the duration of bleeding in days before a diagnosis. And you can see on the bottom that in a patient who presented with stage 1 disease with bleeding, their bleeding duration was only a mean of 88 days. But if we go all the way up to the stage 4 line here, we have a median of over a year of rectal bleeding before being diagnosed. And that is telling to us. These are small numbers, but telling to us and makes sense. The longer you have these symptoms, the longer you don't know that it's important, the longer your healthcare team does not listen, the higher stage you'll present when you're diagnosed. So I think most important thing really from today, you guys, is just this awareness that many young patients are unaware of the diagnosis and the key symptoms, that when we don't acknowledge or the patient doesn't know that these are important, that we will present with later stage disease because of lack of screening and delays in diagnosis. Okay, so what is the cause? That's the million-dollar question, right? Why? Why do we see these trends and changes in our country? And of course, our initial thought would be, oh, these are young patients. They must have a germline genetic alteration, right? They must have a hereditary cancer syndrome to explain this. And that's the case to some degree, but doesn't explain everything. So if you look on the left, the table on the left shows early onset colorectal cancer, and you can see that pathogenic germline variants or alterations related to hereditary cancer syndromes are present in 16 to 25% of patients. But that's not too different from the group on the right, which is CRC of all ages. And so that's 10 to 15% of patients have pathogenic germline variants. And so how do we explain the 75 to 84% of patients who have sporadic colon cancers? Why are we seeing those changes? And the truth is we don't know. I'm sorry I don't have the answer for you today, but I want to bring up some of the areas that there's a lot of ongoing research and interest that we are hoping to have more data to share with you in coming years. And I think the first and foremost is just to say that we don't even know where in our life that exposure, what the exposure is, or where in our life it might occur. And so there's research ongoing in all areas, even as early as fertilization, even as early as the prenatal period, but then absolutely throughout all ages of infancy, childhood, adolescence, and adulthood, to try to pin down what are the most likely causes that we could change or intervene or step in against. And so a lot of the research currently is focusing on how we might see this through the microbiome. And the idea being that our cancers are developing in the bowel. What is the environment of the bowel that might be variable in patients and that also might be affected by our exposure, so what we eat or how we act. And so what they have found is that there can be changes in the genome and epigenome, so genetic changes that could be taking place in these normal epithelial cells of the bowel based on the variability of the bacteria and normal flora in the gut. And so this can happen in a couple of ways. So on the top is listed the particular individual bacteria that they have linked to colorectal cancer. And you can see in the images here that they have listed particular bacteria that may act in specific ways in the bowel. So for example, the first image A shows particular bacteria that may induce chromosomal instability in the normal epithelial cells or DNA damage. The second, number B, shows that there are multiple bacteria that may induce changes in methylation of the DNA. And then D shows that even microRNA may be affected by very specific bacteria. So that's one potential mechanism. The second, though, is on the list below that there may be, the prevalence of bacteria may be important, right? Like how many of this certain bacteria or the the variation of bacteria in the bowel, that pattern may be more to do with it. And so we think of that particularly, these are things that are just inherent to us. We all have that different microbiome as we're born. But there also may be effects on that, including antibiotics, that might change or alter that microbiome over time. And so that may do many of these things, like change methylation, but also in histone modification as well. So the microbiome is kind of the big focus right now. Like, what is the research going in to try to understand this increase in early onset colorectal cancer? But what are the factors that may affect it? Like, what are the things we're looking at? What are the things we can think about to change? And so one area of particular interest is in obesity and high-fat diet. And how may it interact with the microbiome? The thought is that there may be direct effects on mitochondrial function, which then can change that microenvironment and lead to increased prevalence of certain bacteria over others. And then other areas that we'll kind of touch on more briefly, including antibiotics and other outside factors that might impact the microbiome. But we'll spend the next couple of minutes just walking through some of the current research about obesity and effects on the microbiome and thus colorectal cancer incidence. So this is data from the Nurses' Health Study 2. So this is 25 to 42-year-old women between 1989 and 2011. It's more than 85,000 women who were followed, and of those, there were 114 cases of early onset colorectal cancer. So this is not big numbers. This is not common in this population. But when we looked closely at the patients, again, very small numbers. Like if you look according to BMI, the number of patients here we're dealing with is 20 to 30. But we do notice a trend with increased risk of colorectal cancer, early onset, with increased BMI. And so that was also preserved. You can see the top graph is indicating that all participants, and the top part of the graph shows those without a family history of colon cancer. So trying to kind of minimize the other risk factors that might be at play here. So definitely a suggestion that obesity could be some part of this. But what about men? This didn't include any evidence of men. So there is a study from the Danish Cancer Registry looking at 751 men. They looked at it slightly differently. They said, okay, what about weight at different time points in the life, right? Like thinking about this idea that maybe there's different exposures or time periods where this is most important. So they looked at men at age 7, age 13, and early adulthood. And they said, are they normal weight, which is NW here, or overweight, OW? And what they found when they compared to a man who was normal weight throughout their life, that a man who was overweight throughout their life, there's a much higher risk of developing colorectal cancer in this Danish Cancer Registry subgroup. So this study looked at it similarly in kind of a bigger fashion, looking at a case control format. And you can see on the left column, we have cases. So these are people who developed colon cancer at an early onset. And on the right are the controls of similar age. And you can see what we're really focused in is the red part on the right. Those are the people of the highest BMI. So basically what they looked at is that, and found, is that at different age groups, so in the top row, age 20, The middle row is age 30. The bottom row is about 10 years before their diagnosis of colon cancer, that the BMI overall, there were more patients that had a BMI of 30 or greater, which led to believe that this is a risk factor for colon cancer. So what do we know? So let's talk about what we've been through and then some of the other areas of interest. But I think the short story here is it's kind of confusing. So we've talked about 2-3 studies that demonstrated some effect of or link of obesity to increasing risk of colon cancer. So the top 2 here, females with a BMI over 30 and higher weights in childhood that persisted to adulthood in men were associated with higher odds of early onset colorectal cancer. But interestingly, there was a study published in 2020 in veterans suggesting that obesity was associated with a lower risk of early onset colorectal cancer. And then what's the evidence for antibiotics, antibiotic use in colon cancer? There's the same study. They looked at people with colon cancer and people with rectal cancer, and they found an association of prolonged antibiotic use with higher risk of colon cancer, but a lower risk of rectal cancer. Then there's a third study that showed no association, so a totally different trial that asked the same question and showed there was no association either way with early onset colon cancer. And what about other factors that might impact the microbiome, like alcohol use? Alcohol use, there was one trial that showed higher odds of early onset colon cancer in men, but not in women. And then more recently, there was a trial thinking even farther back to cesarean delivery. Does that affect our microbiome if we are born through cesarean delivery versus vaginal delivery? And they found females born by cesarean delivery had a higher odds, but males did not. So, I think all of this kind of goes to show us there's definitely nothing here that's a standout that we can point our finger to and say, let's act now. This we need to change. In fact, I think it asks more questions than answers, but helps us to kind of identify and narrow down our focus and realize that we have more work to do. I think the gut microbiome remains a high area of interest and area of ongoing exploration. But it's very clear that there's multiple factors that can influence this, and they can influence it over time. And I think the moral of this story is these association studies like we're trying to do, and that it's the best we can do in this situation, are really limited by numerous confounding factors. We can't tell what's the most important thing here. And I think the areas that we're hoping to move forward and really be able to answer more of these questions the next time we talk would be, what are the environmental factors in particular, and where in our life cycle are they most important? Is it in utero? Is it in early adulthood? Where in between? And then I think the ultimate goal, of course, would be if we can identify these factors that make a person of higher risk, then we can propose these factors to allow us to screen patients with those characteristics at a younger age so we can find these cancers before they're stage 4. So these are the areas that we're really focused on working and improving early onset colorectal cancer. And what we're doing today is education and awareness. I think that's first and foremost. We want to educate all the healthcare community about this problem. But areas that really need our attention moving forward, screening, we need to change screening for these young patients. We can't wait till 45 for most of these people that we're meeting in our clinics. But in order to do that, we need to better understand the disease. We need to propose what are the mechanisms. How can we find this high-risk population so we can really get traction to screen at a younger age, because that comes with a cost. And then finally, for the people who already have this, for the young patients we treat in our clinic every day, what are the things that we need to change in their treatment paradigm moving forward? How do we need to approach them differently? What are the needs that may be different than how we would treat a 50-year-old? So take-home points for today: early onset colorectal cancer is rising in incidence. It is a worldwide trend, and in our country it seems to be maybe portions of the United States are more likely to have this problem, and also that sidedness of the cancer, rectal cancer and left-sided colon cancer, may be more at risk in this population. Awareness is vital, not only for the young population, but as well as us as healthcare providers. And that unfortunately, so far, the environmental and genomic studies that we have performed show some associations and some concern, but there's no clear factors associated with causation that we can act on at this point. And we have more work to do in the gut microbiome and early life exposures. And then finally, we really want to work on advancing research in this area, but it's hard to do. These are not the most common cancers. This is a rare, though increasing situation. And so we really need to come together as institutions across the country to collaborate with our research, with our patients, and help come up with more innovative hypotheses. That's all I have. Thanks so much.
Thank you so much.